Diagnosis and treatment of personality disorders is a contentious issue at the best of times. When it comes to people with an intellectual disability, it is even more so. And yet, most practicing clinicians in this field, and indeed many experts by experience, would recognize the presence of a small but significant number of people who broadly fall into this category. Within the context of health services in the United Kingdom, this is a group which has the uncanny knack of falling precisely between the boundaries of mainstream mental health and specialist learning disability services. Too disabled for one, too disordered for the other, they fulfill the exclusion criteria of both services. And yet there is no mistaking the real intangible distress that many people in this group and those around them go through.
This training video is a practical exploration around the key themes in this group. Many of them will be in contact with the criminal justice or forensic systems. This video covers the following topics. Firstly, personality disorder and personality. Secondly, objections to making this diagnosis. Thirdly, reliability, validity, and clinical utility of this diagnosis. The different approaches to diagnosis. Treatment and treatment outcomes, and finally, staff training issues.
Let us start with an introduction to what normal personality is before moving on to the question of personality disorder. So in plain English, personality refers not just to observable patterns of behavior, but also to patterns of thinking and feeling. And it is important to appreciate this because when one makes a diagnosis of a personality disorder in someone with an intellectual disability, you are relying not just on patterns of behavior that are concerning for the observer, but also the individual's own patterns of thinking and feeling that led to that behavior. One of the structural models of personality that I find particularly useful in this patient group is one that is based on three factors: temperament, character, and intelligence. Temperament, broadly believed to have a genetic and biological origin, is what you are born with, something that you perhaps have little control over. Character is what develops in relation to your interaction with the environment. So that is an acquired part of your personality, and your adverse life experiences may play a role in shaping that component. Thirdly, intelligence as a factor helps in molding the combination of what temperament and character have done together. If we put that structural model to one side, perhaps the best evidence base for personality dimensions come from the 5-factor model of personality. And those factors are behind me, starting with neuroticism, also referred to as emotional stability or emotional instability. This is distinct from the Freudian concept of neurosis. Neuroticism in this context is essentially the capacity of the individual to feel negative affect, from anger to anxiety, from depression to sadness to dysphoria. And you will see that each of those factors exists on a continuum, and too much and too little can be problematic. Next to neuroticism, you have extroversion, which is the individual's relationship with the external environment. You then have openness to new experiences of different kinds. And the final two factors are agreeableness and conscientiousness. And the definition of those two terms are very close to the ordinary meaning of those words in the English language. So conscientiousness essentially is your approach to tasks and duties and so on, while agreeableness is really an index of how well you get on with others. And of course, there are much more detailed explanations and other sources of information that you may have about these topics. Now that you have a general understanding of what normal personality is and the starting point of personality disorders, let us specifically examine what are the objections to making a personality disorder diagnosis in someone with an intellectual disability.
So the objections to making a diagnosis of a personality disorder in this group can be split broadly into philosophical issues and pragmatic issues. If we start off with the philosophical issues, the first part is the issue of stigma. So people with a learning disability or an intellectual disability are already part of a marginalised group. We have to have realistic concerns about adding in a diagnosis that is also known to be stigmatizing, such as that of a personality disorder. Perhaps the last thing they need is a label that is going to contribute more stigma and more marginalization. Then you have the developmental theorist position. And the developmental milestones in a learning disability are delayed, whether that's motor milestones, whether it's speech, whether it's adaptive functioning. Across all the different areas of development, we might see a degree of delay. Does it not hold true then that there might also be a delay in the development of the personality? And when it comes to understanding the personality or diagnosing a personality disorder, at what point is the personality sufficiently matured in order to reach that diagnosis? If one's personality is still developing, how can you diagnose them with a personality disorder? And finally, you have the potentially confusing overlap between some of the personality dimensions that Professor Alexander described earlier and the personality disorder diagnoses as well. Now, when we consider the pragmatic issues, one that stands out is that of communication skills. The diagnostic criteria of many of the personality disorder assume a certain ability to communicate, whether that's communicating patterns of thinking and patterns of feeling, the way that they see the world to the clinician. But very often, developmental disorders of the type that we're looking at will also come with a degree of communication impairment. And to what extent will that then impact on how well we are able to reach a conclusion about the personality in the way that we otherwise would? The second aspect that's a challenge pragmatically is the overlap or overshadowing between some aspects of the intellectual disability and the personality disorder. And perhaps the best example of this is the dependent personality disorders, because someone with an intellectual disability is going to have a higher degree of dependence on other people. They are going to rely on other people more so perhaps than those in the mainstream population. This creates challenges when it comes to separating that dependence out from the personality disorders that also feature a high degree of dependence. And the same might be true of oddities in social communication that are typical of things like the schizotypal personality disorders as well. And finally, you have the issue of which instruments you can use. There aren't tools that have been validated for the use in people with an intellectual disability. There aren't tools for diagnosing a personality disorder that have been validated for those with an intellectual disability. So we have a whole set of problems, and yet the diagnosis does seem to have some degree of clinical utility that we'll look at next. So to explore this area properly, let's take a broader view, looking at reliability and validity before we then consider clinical utility. So when we talk about reliability, really what we're talking about is repeatability. If I use a set of criteria to assess a patient and come to a certain diagnosis, and then another colleague uses those same criteria to assess the same patient, are they going to come to the same diagnostic conclusions that I did? That's what repeatability is like. And really, that's what we mean when we talk about reliability. And when you look at reliability in that context, well, the results when it comes to personality disorder don't seem all that encouraging. If you take a look at this range of studies looking at prevalence of personality disorder in this group in the community, you find a prevalence that ranges from less than 1% up to 91%. And how useful is any of these tools if that's the breadth that we see in terms of the reliability? A huge range as to whether or not we're likely to reach a diagnosis. And when it comes to hospital samples, we still see a very wide range, somewhere between 22% in some studies up to 92% in other studies. And again, this is too broad a range to be useful to us. But are there ways that we can make for a more useful sample? In light of these findings, some working in the field have adopted a more pragmatic approach that brings in certain restrictions that help to provide a more useful sample. So, if you start off by looking at a higher age cutoff, we mentioned earlier about the challenges of personality maturity. Well, actually, if you look at people aged 21 and over, that's helpful. If you limit the range of learning disability, so you look at those with a mild learning disability, you help the engagement of some of the other aspects that we've talked about. And if you limit the cluster of personality disorders that you're looking at, so instead of looking at all of the different clusters, whether you just look at what they would call the flamboyant cluster, so that's the borderline type, the dissocial, the emotionally unstable type, then you remove some of those issues that we earlier talked about in terms of dependence and in terms of some of the more schizoid, schizotypal personality disorders, and come to a group that's much more useful to look at. And when you take this approach, you come to a prevalence with a much narrower focus. So about 5 to 7% for community teams and about 50% for forensic inpatient teams. Now, what about the issue of validity? By far the best research validation variable is that of trauma, the presence of trauma. And most people with a learning disability and a personality disorder will have had some experience of trauma. Now, this has led some to urge that this should be considered along the lines of the complex PTSD diagnosis instead of personality disorder. But there is rather a growing body of evidence suggesting that there are crucial differences between personality disorder and complex PTSD, particularly in the general adult population. So finally, whatever the controversies, the diagnosis of personality disorder does have some clinical utility for reasons that are outlined there in terms of a number of different studies that show, for example, that it seems to influence the ability to place or successfully place someone in the community, that it's helpful in predicting future psychiatric morbidity, that it helps to predict the rate of referrals, that it influences the mode of management, and it can help to predict the outcomes for patients discharged from a forensic setting. Now that we've explored the importance of the diagnosis, let's explore some of the different diagnostic approaches.
So in this section, we are going to examine 3 different approaches to the diagnostic process: the categorical, the dimensional, and a brief mention of what is generally referred to as a motivational model of personality. Let's start off with the most commonly used in healthcare systems, which is really the categorical approach to diagnosis. So, those of you working in hospitals or indeed in the community would know there are 2 widely used classificatory systems in the world. The World Health Organization, the WHO, publishes what is called the International Classification of Diseases, the ICD. What is used in the NHS now is version 10 of the ICD, although version 11 has already come out and may be introduced in the next couple of years or so. And the Americans follow a system called DSM, which is the Diagnostic and Statistical Manual. And the general approach to diagnosis in both of these systems is almost the syndromal approach to medical diagnosis. So you have a list of symptoms or characteristics, and if a sufficient number of them are present in an individual patient, that patient is meant to have that diagnosis. And I'm not getting into arguments about the validity of that approach and the absence of a pathological basis, but this is the approach that is most widely used for mental disorders. If you look at the category of personality disorders in ICD-10 or indeed in DSM-5, let's take DSM-5 as an example. There are 9 diagnostic categories which are mentioned, and they're divided into 3 clusters. And you might have heard a little bit about that in Phil's earlier section on diagnostic reliability. So you have the schizoid, schizotypal cluster, you have the so-called flamboyant cluster of personality disorders, typically borderline and antisocial, and then you have the anxious avoidant cluster, which is the avoidant personality disorder, the anancastic personality disorder, and so on. So in the DSM, 9 diagnostic categories split across 3 clusters. And again, in diagnostic reliability terms, you would have heard that in people with intellectual disability, clinical utility will be increased if you focus only on the flamboyant cluster personality disorders, i.e., borderline and dissocial personalities. What I want to move on to next is the dimensional approach to personality and personality measurement and understanding and formulating people's presentation issues. I've already touched on this right at the beginning when we did the introduction. The most widely used is the 5-factor model of personality. And just to remind ourselves of the 5 factors, there is neuroticism, the capacity to feel negative affect, extroversion, openness, agreeableness, and conscientiousness. What is interesting is rather than the dimensional and categorical models being completely alternate systems, both the DSM-5 and ICD-11 is moving from a completely categorical approach to a greater appreciation of dimensions of personality, certainly in formulation. And you can see behind me this slide, which is rather dense. Again, I would suggest that you pause there and have a careful look at that slide. It's taken from a textbook edited by Marco Bertelli and others. It's called Psychiatry of Intellectual Disability and Autism Spectrum Conditions. What that table does is to examine each of the dimensions. So the first column, it's titled healthy polarity. So emotional stability is the term used instead of neuroticism. And then there is a pathological polarity at the other end. And what are the pathological facets? So if you take a personality dimension like extroversion, that is the healthy polarity. Its pathological polarity would be detachment. And then the facets, the pathological facets could be a range of things from intimacy avoidance to withdrawal to anhedonia, a tendency to be depressed. It's described as depressivity there, and a restricted affect. What this does, if you combine the categorical and dimensional approaches in this way, you are able to formulate with a much richer vocabulary and thereby help your patient better. And that has been the general experience of clinicians in this area. And once ICD-11 is widely introduced in this country, it adopts a far more dimensional approach than what we are used to so far. I want to end that section with a brief mention of the motivational model of personality. Now, this understanding, this comes from Edward Siegler and his colleagues at Yale. And this approach to personality difficulties in people with intellectual disability is completely far removed from the mainstream of academic thought, which underpins the 5-factor model. What Siegler and colleagues suggested was the repeated failure experience in people with learning disability changes their problem-solving style, and it leads to the avoidance of normal and challenging tasks. They expect to fail and look to others for cues. So Siegler set out 5 personality traits that differentiate a person with a learning disability from their peers. And on 3 of those traits, he said, people with learning disability would score higher than those without, and on 2, they score lower. And let's look at them as they come up on the slide. So the first is something called positive reaction tendency, and this is the heightened motivation to interact with and be dependent on a supportive adult. The second is called negative reaction tendency, and this is the initial awareness that is shown when interacting with strange adults. And the third is what is called outer directedness, and this is the tendency to look to others for cues to solutions of ambiguous or difficult tasks. And on these 3 factors, people with learning disability tend to score higher, and on the remaining 2, they score lower. The fourth one is expectancy of success. So the degree to which one expects to succeed or fail when presented with a new task, people with learning disability score lower than the control groups. And the final factor is called efficacy motivation. And this is the pleasure that is derived from tackling and solving difficult or novel problems. And so these 5 factors, regardless of where they sit in the mainstream of personality literature, does strike a chord with many of us clinicians, and I'm sure many of you would recognize these patterns in the patients you treat. And I'll end that section by re-emphasizing that point, an awareness of these alternatives to the categorical model of diagnosis. An awareness of that will improve your capacity to formulate and intervene better for your patient groups. Let's now move on to the next section. Let us now examine the issue of treatment and treatment outcomes. Those of you who watched our previous training video on autism spectrum conditions would be familiar with the structure of the 10-point treatment program. We follow broadly that structure for this condition as well. To begin with, if one looks at the best sources of evidence, they are the NICE guidelines on this and related topics. And coming up behind me, I have put the key guidelines there. So there are 2 specific NICE guidelines on personality disorders. They are on antisocial personality and borderline personality disorders. They're quite thick volumes, and sometimes the thickness or how big a NICE guideline is unfortunately a reflection on the limited quality and quantity of evidence. And so there's quite a bit of expert opinion and expert consensus included in those guidelines. So anyway, 2 on personality disorders. And the next 3 that you can see up there are all related to intellectual disability or learning disability. So there's one on challenging behavior, there's one on mental health problems, and there is one on service delivery and service organization. And related to learning disability, but in terms of another or a different neurodevelopmental condition, there's one NICE guideline on autism and one NICE guideline on ADHD. So much of the sources as far as effectiveness of treatments and interventions go have been summarized. If you cover these 5 to 7 NICE guidelines, you get most of the evidence in there. As I said before, the best way of conceptualizing the treatment program is a 10-point treatment program. And in the next slide behind me, I show although we say 10 points, they are based on 4 phases of treatment. The first phase is obviously the assessment phase. You then have the treatment phase. You then have a consolidation phase. And finally, there is what has been described in the slide as discharge, but it could very well be marking the end of therapy and interventions, and the person is discharged from active healthcare. So if these are the 4 stages, what are the 10 points? And I would invite you to go back and view our autism training program where we deal with it in much greater detail. So behind me, the slide shows the 10 stages, the 10 points of the treatment plan, starting with diagnostic clarification, psychological formulation, a risk assessment and management plan, a behavior support plan, usually following positive behavior principles. You have pharmacotherapy, you have psychological therapy, what has been described as foundation treatments, and they are really personality disorders symptom reduction treatments. So from anger management to management of emotions to assertiveness training and so on, or offense-specific interventions, which either target anger and violence or sexual offending or fire setting and so on and so forth. And then you have a structured program of daily activities which have an occupational and rehabilitation and educational focus. And you have, if you're dealing with people who are detained within hospitals, you have a gradual reintroduction into the community, culminating in a discharge process. So I want to briefly mention the primary sources. I have shown the textbooks and guideline sources, but I wanted to make a brief mention of medication use in the management of personality disorders in this group. And in intellectual disability, the dividing line between a personality disorder related presentation and a challenging behavior related presentation, particularly if the person has a mild intellectual disability, that dividing line can be rather thin. And psychotropic medication is used quite widely. If one relies on the NICE guidelines for personality disorders, the advice is pretty clear. There is no medication which is licensed for use in a personality disorder, and therefore do not prescribe, certainly long term. At the same time, point number 1 of the 10-point treatment program, a robust diagnostic clarification which clearly rules in or rules out comorbid mental illnesses is quite important. And if there is comorbidity, you treat it rationally and you treat it according to the guidelines. So do not prescribe for personality disorder alone. Treat comorbidity. If the risk to others and the risk to themselves and the distress cost is quite prominent, and treatment is indicated, at least in the short term, the approach suggested has been the approach of symptom clusters. And behind me, the slide shows the 4 or 5 symptom clusters, starting with cognitive perceptual, which is really brief lasting psychotic presentations, or presentations of psychosis like symptoms where you can never be sure whether it is truly a hallucination or a pseudo hallucination or vivid mental imagery. So the first symptom cluster is cognitive perceptual. You have other clusters, and you can see them coming up one after the other behind me. And the first line treatment and the second line treatment for those are also mentioned. This is drawn from arguably the only treatment guideline available for people with neurodevelopmental disorders, which is the Frith treatment guidelines, now into its 4th edition. And you might want to pause the presentation there and have a careful look at some of the things that are mentioned on that medication slide. In terms of psychological interventions, again, you can see the key points there. Rather than a particular school of psychotherapy, what is important are the 5 factors that are shown there, from structure to a predictable sequence of events and so on. So the school of psychotherapy is arguably less important than the emphasis on the points on the slide. And the evidence base for this is largely case reports or case series, certainly very, very limited number of double-blind or randomized controlled trials. And again, the reference on the slide shows the chapter by Peter Langdon and colleagues, which offers an excellent summary of the state of evidence in this field. So I hope that is an overview of the treatment approach, and this is what is followed probably in most inpatient settings who treat people with this condition, and indeed a number of community forensic learning disability or forensic neurodevelopmental teams also follow the same approach. If this is the structure of treatment, it is worth looking at whether treatment works. Not the audit standards in terms of practice standards, how quickly you see someone or how quickly you discharge, but at the end of that, at the end of all those process variables, does your treatment actually work? And that is what Phil is going to examine in the next section.
So to examine treatment outcomes, we want to look at 3 studies in particular. The first of which was about long-term outcomes. This looked at patients from an NHS medium secure unit. This showed that the diagnosis of personality disorder increased the odds for reconviction. Well, this is striking because a diagnosis of something like schizophrenia significantly reduced the odds of reconviction. But for those with a personality disorder, the odds of reconviction were notably increased. We look at the second paper. This was, again, looking at a secure unit in the east of England, looking at a significant number of patients with personality disorders in offenders with intellectual disability. And what this showed, when you compared them on a more short-term basis, so at point of discharge, was that there was more similarities than differences between the 2 groups. And then the third paper looked at 3 groups, so personality disorder, intellectual disability, and personality disorder in patients with an intellectual disability. And what this showed was that there were, and really this was about whether there was more similarities or differences between the groups, how they compared across the 3. And it showed that the pre-treatment variables, the PD-LD group, were closer to the personality disorder group. But when you look at the post-treatment outcomes, they were closer to the learning disability group, which is positive in terms of the impact of treatment. So having looked at the treatment outcomes from those 3 papers, we're now going to explore some of the issues around staff and staff training for the final part of this presentation.
So let's come to the last bit of this training video, and that is addressing some staff training issues, particularly when it comes to people with personality disorders and intellectual disability. One of the paradoxes in this area is the professionals or the people who have staff members who have the maximum contact with service users in this category often have the least amount of training, specialist or otherwise. I'm talking about healthcare assistants, social care support workers, and so on. And perhaps one of the best reference articles that I have read on this topic was written by Estelle Moore. It's about 12 years old now, the article. It came out in Advances in Psychiatry, published by the Royal College of Psychiatrists in 2012. But the core messages in that article, the contributions it makes to training, are still relevant, perhaps for the foreseeable future. What I'm going to do is to highlight 3 or 4 aspects in that article and invite you to read the full text, which is freely available online. You can search using the title, and you should very easily find it on any search engine. The first thing is that whether you are a healthcare worker or a social care support worker, you should be aware of some of the core issues that are associated with people who have a personality disorder. This is true regardless of whether they have an intellectual disability or not. The difficulty in asking for help and often presenting in a crisis mode. A kind of ambivalence about seeking treatment, seeing attempts of professionals to provide treatment as over-intrusive, controlling, and seeing approaches from professionals as leaving them to it being interpreted as rejection. And this lack of trust in others and fear of intimacy often comes from a compulsion to reenact the damaging aspects of their formative relationships. And it also leads for many service users to misinterpret the motives of others, particularly when they are emotionally aroused. And this in turn leads to what is described as pseudo-attachment with the professionals who are involved with them, and the use of what are described as controlling strategies to come to terms with their sense of self and their impulsivity. And all this is worsened when they are in a relatively new or unknown environment. It is also important for health and social care support workers to know about the common tests of staff integrity when what is described as toxic transference occurs in personality disorder services. They have to be aware that service users may compare various members of nursing and multidisciplinary teams and indeed their decisions. They might have a pattern of providing minimal information to a member of staff to see how they cope, make a high number of complaints, or ask the same questions to various members of staff to see how people respond, and may refuse to follow recommendations for treatment. And this is often an emphasis of staff vulnerability rather than their own. They might single out certain staff members either for special attention or gifts and favors, or at the other end, criticism or assault. And in the process, they create splits within the professional team. The next important thing is for support staff to be aware of unhelpful responses to these patterns of toxic transference. And that varies between two poles: an unhelpful response of total rejection and attempts to over-control, and an equally unhelpful response of becoming over-involved. So when you think about rejection and over-control, staff should guard against dismissive and belittling attitudes to service users, the increased use of restrictive intervention, including the inappropriate use of psychotropic medication, and the tendency to portray patients and service users as, quote, attention seekers or manipulative troublemakers or not mentally ill or bed wasters and so on. So if this is the rejection pole, equally unhelpful is the over-involvement pole. So there can be patterns of disagreement within teams that are rehearsed in the presence of patients, and the criticism and belittling of other professionals, and the failure to put the true interests of the patient first and collude with boundary violations. And almost seeking a special privacy in a particular professional's therapeutic relationship and so on. So it's important to be aware of both poles, equally unhelpful. And the final thing I want to highlight there is what are the strategies, and this is a general overview that managements, whether they be in healthcare or in social care, can adopt to promote health and recovery in services that cater for service users with personality disorders. The most important is perhaps that second bullet point, which is you need to select a staff group which is motivated for the right reasons to come into the personality disorder service. And it requires a particular type of personal attributes for staff groups to thrive in this environment. And the Estelle Moore article provides greater detail of this. It is also about providing training on personality disorders, boundary setting and maintenance without tipping over to either over-involvement or unfair rejection. And this is where you promote this empathic balance between trust and control and sharing of decisions. It's very important to establish a culture of a reflective inquiry without blame. In terms of day-to-day interactions, whether they be on the ward or in a social care setting, training on the appropriate use of humor to promote an empathic relationship is quite important. It is also important to teach patterns of responding swiftly to rule breaking, but doing it in a calm and collected manner. The key phrase being firmness without retribution. So boundary setting without tipping over into punitiveness. Equally important is to provide opportunities for either the detained patient in an inpatient unit or people with personality difficulties in a social care setting to provide opportunities for them to appropriately let off steam. And finally, the standard phrase in any training, which is to communicate the learning points from serious incidents and setbacks directly to all staff. As I said before, this is an overview of some of the staff training issues. Do find this article from Estelle Moore. I do not know the person. I do not know her personally at all, or indeed professionally, but it is an article that I have found extremely useful over the many years that I have spent in this field.
To end this training video, let us recap on the main points. Firstly, personality disorder in those with an intellectual disability is not just about patterns of behaviour, but also about patterns of thinking and feeling. Secondly, diagnostic reliability is better when limited to patients with a mild intellectual disability or disorders in the so-called flamboyant cluster. Thirdly, trauma is common in this group. Fourthly, diagnosis has clinical utility. The 10-point treatment program provides a useful framework for people in this group. And finally, treatment improves long-term outcomes.